Good evening. This is Dr. Victor Gonzalez. I'd like to welcome you to tonight's webinar, entitled Macular Laser Therapy, a closer look at the Pascal Laser and Endpoint Management. Joining me today are two very distinguished panelists, Dr. Yanis Paulus and Dr. Francisco Rodríguez. Today we will be sharing our experience with the Pascal Laser. You'll be listening to some of the parameters that are being used for treatment with this laser, the different macular diseases that are being treated with a laser. And also we'll have an opportunity to have a discussion after the presentations are given. You can submit your questions through either the Q&A section on your Zoom page, or you can directly use the chat to send us any questions you may have. Without further ado, I'm gonna start the session today. As we know, there's been a lot of challenges that have occurred, and quite often, you know, we hear that the laser is no longer a useful tool in the era of the anti-VEGFs, but I'm here to tell you as a lover of the anti-VEGFs originally. I think very early on in my training, I realized that they were not the cure-all, and certainly, you know, the laser was still going to be very important. The topic I will discuss is the use and the utility of the laser for the treatment of macular diseases in the anti-VEGF era. Today, a few of the take-home messages are that a variety of macular diseases can be effectively treated with the lasers, even in the presence of anti-VEGF. There's no doubt that anti-VEGF therapy has become the first-line therapy in many macular diseases. Good visual and anatomic results can be achieved with monthly application of these drugs. But as you will see, laser treatments are required and were required in many of the patients in the large clinical trials. And the introduction of tissue-sparing laser treatments appear to be important in the management of these conditions. Just a practice overview so you can understand our practice. I come from a large retina practice. You know, there are 4 retina specialists and 3 retina fellows. You know, with a large population of diabetics, about a 25% prevalence in our community. Many of these patients, unfortunately, are poorly insured, and for that reason come with very complicated conditions. During the winter months, we have a large influx of winter Texans, so our incidence of macular degeneration, you know, soars between November and April. And as part of what we do down here, we have a large research program. And how have we incorporated the Pascal laser into our practice? Well, the laser has been very helpful in treating, you know, particularly our diabetics. As you can imagine, you know, remembering those old days where you were having to put single applications for PRP, you'd be there, you know, 20+ minutes treating some of these patients. With the pattern treatments, we can now very effectively and very quickly treat these patients. Being able to vary the treatment using these patterns appears to be less painful to these patients, and the patients report much more comfort. And also these sessions tend to be a lot faster. One of the very important aspects that really isn't discussed with the use of this laser is the positive effects on practice management. And what do I mean by that? Well, you know, since we see a lot of diabetics, we require a lot of treatments. So being able to place a PRP treatment and complete it in 1 or 1.5 sessions is very helpful. That allows us to, you know, put more patients through the clinic, giving us an opportunity to either go home earlier or see more patients in the clinic. And that's what convinced our practice management team that this was a very essential tool, not only to better treat the patients, but also to improve the flow and the benefits in the clinic from a practice management standpoint. Now, there are many of our colleagues that will tell you to throw away your lasers because, you know, with the anti-VEGFs, all you need is the anti-VEGFs. But as you can see, when I review these clinical trials, you'll understand that that in fact is not completely true. This is the protocol I rationale. And remember, in this study, we're comparing the drug versus delayed or active laser. And as you can see, and we all agree that the combination of the drugs compared to the laser itself had much better and superior outcomes, particularly at year 1 and beyond. But when we look at other anatomical outcomes and how we achieved these outcomes, it wasn't just the drugs, as you will see. You can see the nice gain in lines in both the delayed and the prompt laser group with using the drug. In this case, it was ranibizumab. You see a nice percentage of patients with that gain 15 letters. The majority of them being the ones that received the ranibizumab versus the laser. But you can see even with the laser, there was a good percentage of patients that gained 3 letters. And of course, the reduction in macular thickness was much faster and superior when we used the drug versus the laser. But again, you can see over time, there is a decrease in central macular thickness, even with a laser. Now, what they don't tell you is this, and that is in order to achieve those results, as you can see, even particularly in the deferred laser group, which didn't require laser at the beginning, yes, 70% of the patients required no laser, but 30% of these patients actually required a laser. So when you look at the results of that arm, that combination arm also required laser treatment. So unlike what the perception is, and that is that only the anti-VEGF was used there, actually 30% of those patients required lasers to obtain the outcomes that are reported in the studies. Well, how about protocol T? Well, protocol T was very important in that, again, we saw very significant outcomes with the use of the anti-VEGFs. But here we learned 2 things from this study. Not only was it important on which drug you use in terms of how many lasers were required, as you can see, aflibercept, even with the best of the 3, 41% of those patients required laser over a 2-year period. 52% with the ranibizumab, and you look at bevacizumab, 64% of the patients in protocol T required a laser treatment. So again, in order for you to obtain those great outcomes with those really high number of letter gains using these drugs, a large percentage of these patients required laser. How about Rise and Ride? To me, this is the most intensive protocol that we have for DME. And even with monthly injections of ranibizumab for nearly 3-year period, we learned a couple of things, right? You don't want to delay your treatment on these patients, because even if you start the proper treatment, which is the anti-VEGF, you don't ever regain. But what percentage of these patients actually required laser in this very rigid clinical trial? And as you can see, with a 0.3, almost 38 to 40% of them required the drug. And this is the dose that required laser, sorry. This is the dose that's approved in the US for DME. 0.5 is approved for the rest of the world, but even with the higher dose, about 30%. So again, in order for you to obtain these results, you need treatment with a laser. Now, this is not the type of laser we're talking about. This is what we're trying to avoid. What we want now is to provide laser treatment that is not going to cause a negative effect to the tissues. And this is where the concept of non-damaging retinal laser treatment comes from. There's a difference between ophthalmoscopically visible and ophthalmoscopically invisible, right? But even within ophthalmoscopically invisible, just because you don't see a lesion does not mean you do not have damage to the tissue. And that's what this is showing here, that even though you can't see visibly the burn, you can see that there's been damage to the tissue when we look histologically. This is the Arrhenius integral. And what this integral shows is the interaction between tissue and laser energy. And you can see there's a small window for therapeutic effect before you start seeing damage. If it's subtherapeutic, obviously you're not going to benefit the patient. But if it's beyond this interval here, you're having a beneficial effect, but you're also causing damage to the tissue. Now, what is the goal with laser in any laser treatment? Actually, as it turns out, it's the production of heat shock protein. And as you increase the energy in these patients, you can see that the amount of heat shock protein increases, but there's a limit. And that limit results in damage to the tissue if you go beyond that. Histologically, what this looks like is this. If you do a laser burn in the retina, you can see the viable tissue is this green stain here on the right. And the heat shock protein production is only occurring at the edge of that lesion, which means the viable tissue. So damaging the tissue results in loss of function there, and no benefit, because that's not where you produce the heat shock protein. Now, if you look at this panel, if you treat them with 100% energy, you can see that the heat shock protein is only produced at the edge. But if you now use the endpoint management algorithm and decrease it to 30%, you can see that now the whole lesion produces a heat shock protein, and the tissue is preserved. So this is the type of effect that you want to do. Now, there's always been a concern about, what the parameters should be and which wavelength works or which doesn't. The recommended way for us to use this is to do a barely visible burn out of the arcades inferiorly at 6 o'clock, and this lesion needs to turn barely visible within 3 seconds. Yeah. Normally, the parameters we use are somewhere between 100 to 200, and beyond that, we recommend that one moves with caution. And it doesn't really matter which of the two wavelengths you use; they both work well. The unit has these settings, as standard 15 milliseconds when you go to the tissue sparing. 200 microns, and we recommend the first treatment to be around a quarter spot size in spacing, the energy down to 30%, and somewhere around 500 700 laser applications are given. When we retreat these patients, we consider these as an injection. Remember, you're trying to produce heat shock protein, so we retreat normally every 3 months. And those that haven't responded the first time, I decrease my spacing from the quarter to 0. And even with this, you only treat about 89% of the tissue. So you're not completely painting everything. And this seems to work well for most patients. And remember, just like anti-VEGFs, some of these patients will not have the clinical response that you would like. And you need sometimes a combination of treatment. Here's just a view of what that panel looks like. I do not like to use those little red marks because those are the areas where you can outline where you've treated. I turn those off, but you can see the parameters are pretty set there when you are in this mode. And the only thing that really changes in this one would be the energy, where you can increase or decrease, and then of course, the spacing of the spot size once you determine that you need to increase the density. This is what that treatment looks like with the markers on, and those are our thermal, and that's why I do not use them. But there are some users that like that feature because that gives them an idea where they're at. I won't discuss in depth the use of this, but we can use it in CSR, and Dr. Rodríguez will talk about that. We've used it in DME and different vein occlusions, and even in MACTEL, there seems to be some data that heat shock protein may actually be beneficial. We believe that the structural damage that occurs there is due to Mueller cell dysfunction, and there's some evidence that using endpoint management or this type of treatment may actually activate some repair mechanisms there. So what do you do when you have a patient, you've treated them with anti-VEGF and there's no benefit? Remember that you've got endpoint management, and here's just a quick case. Patient with diabetic macular edema, center involved, who refused intravitreal injections because this would be an ideal patient as a first line for intravitreal injections. You can see that this patient was treated, and there's a few important points that one needs to keep, and that is that you don't get that immediate response with the laser. It's a slow effect, and you may need more than one treatment. You can see there's nice anatomical resolution with improvement in vision in this patient. And this is possible with many other patients with DME. So remember, a variety of macular diseases can be effectively treated with lasers, even in the presence of anti-VEGFs. There's new scientific evidence to support endpoint management as a good alternative for treatment in these patients. Using the parameters developed by the consensus group has made us and continues to be a safe way for us to use this laser in therapeutic level. And tissue-sparing tissues such as endpoint management can be safely used in the treatment of macular diseases. And then there are current protocols that are being developed that will help us further elucidate the benefit of this technology. I'd like to thank you. And I think what we'll do, if it's okay, we'll continue with all the didactic sessions. And then at the end of this session, we'll go through all the different questions. So next, I'd like to turn this over to Dr. Yanis Paulus, and he'll introduce himself and go forward from here. Yanis?
Hi, everyone, and welcome. Thank you very much, Victor, for the introduction, and thank you very much for having me. My name is Yanis Paulus, and I'm at the other end of the country where the people are in the summertime when they leave Texas, and where they flee from to go to Texas in the wintertime right now. So I'm at the University of Michigan Kellogg Eye Center. I have a joint appointment in ophthalmology and biomedical engineering because I run a retinal imaging and laser laboratory. For my disclosures, I serve as an inventor on 9 University of Michigan patents or provisional patents, some related to what we'll be discussing, including retinal laser therapies. I've started 3 retinal laser and imaging companies and serve as a consultant for the listed companies. I'd like to start with a case of a patient that was coming to me for diabetic macular edema follow-up. This was a 61-year-old Caucasian woman, had severe non-proliferative diabetic retinopathy in both eyes, diabetic macular edema, and had constant blurry vision in her right eye. She had been getting with me monthly bevacizumab intravitreal injections in her right eye. This was the summer of 2020, and as we all know, COVID was just raging, and particularly in Michigan, and the patient was very concerned about COVID because she was high risk. We had looked at it, and her copay with aflibercept and ranibizumab were much too high for her to afford on a regular basis. And of note, her past ocular history was remarkable for being a glaucoma suspect, having a family history of very advanced glaucoma, pseudophakia, and a PVD. Of note, her medical history, as we discussed, she had type 2 diabetes for 20 years, suboptimally controlled with a hemoglobin A1C of 10.2, which was actually improved from 12. She had kidney disease related to the diabetes, anemia, electrolyte abnormalities, hyperlipidemia, a very common patient that probably Victor and everyone in this audience probably sees on a very regular basis. She, on the right eye, her symptomatic eye, she was 20/70 pinhole to 20/40. The left eye, asymptomatic, was 20/25. IOPs at that time, 12 and 14. And this is her OCT. So you see this diabetic macular edema involving the center of the fovea. You see it juxtafoveally also. You see exudates with a central macular thickness of 347. And this is despite getting every 4-week bevacizumab injections. So I had a discussion with the patient. She was very concerned because she was high risk to COVID. And she basically said, I'm not coming into clinic monthly. There's no way I'm going to be coming in monthly like I have been doing the past 6 months. And despite that, she still has 20/70 vision. She was very concerned about receiving intravitreal injections of steroids. She was a glaucoma suspect and had a family history of blindness from glaucoma. She was very concerned about the copay. So we decided to proceed with endpoint management. We used very similar settings to what Victor discussed, basically 30% of the threshold. And in her case, it was 130 milliwatts. We performed 653 laser spots. I turned off the landmarks, as Victor mentioned. I also like to turn those off. 200 micron laser spot size, 15 millisecond pulse duration, and a spacing of 0.25 to start with. So this is 6 months after the laser treatment. The patient was so pleased. She went from needing 6 intravitreal injections of bevacizumab in the 6 months before laser to only 2 in the 6 months after laser. Didn't have to come into clinic as often. Her vision had improved from 20/70 beforehand to 20/30 6 months after. Her IOP was stable at 11, and her central macular thickness had improved from 347 to now 279, with a significant improvement in her foveal-involving diabetic macular edema. So this kind of compares the pre-laser to the post-laser, where you do see this significant improvement in terms of the diabetic macular edema. So as you all know, diabetes unfortunately affects so many people worldwide. 387 million people, estimated to increase to 590 million people by 2035. And diabetic retinopathy is the leading cause of preventable vision loss and blindness among working age adults in the United States. And retinopathy affects nearly half of patients with diabetes, costing in the US alone $13 billion a year, resulting in thousands of patients having blindness annually. And photocoagulation has really been established for more than 50 years now as an effective treatment for diabetes and diabetic retinopathy. As Victor brought up, really lasers play a critical role both in diabetic retinopathy and diabetic macular edema. So this is a number of reviews. The one I really actually want to call your attention to is the American Academy of Ophthalmology. So after generous donation from the Munnerlands, there's a laser surgery education center that the Academy put together. They have a really nice website on numerous applications of laser. And there's a section that Mark Blumenkrantz and I wrote on the treatment of diabetic macular edema with laser photocoagulation that I think really goes through a lot of the literature that Victor was mentioning and really goes through how much laser both played a role previously and currently in our management of diabetes and diabetic retinopathy and diabetic macular edema. So it's a really nice resource that I would recommend for everyone if you want to look at a lot of the data and the science and the publications that really get down to how important a role laser plays in our current management, even with anti-VEGF and the importance of it. Mark Blumenkrantz and I also wrote a book chapter on the topic, and then here are some review papers that we've written, including one just earlier this year. So as Victor mentioned, pattern scanning laser photocoagulation, or Pascal, you deliver a pattern of spots with each trigger. So you're limited by the eye fixation time of about 500 milliseconds. So to really deliver more spots, it necessitates a shorter pulse duration, about for 25 spots, 20 milliseconds maximum pulse durations. So the previous single spot application of 100 to 200 milliseconds really wouldn't let you treat that much that quickly. So what we did when I was back with Daniel Palenker at Stanford was do a study looking at the healing of photocoagulation burns after laser application. And we found that 10 to 20 milliseconds is a good compromise between speed and safety. And we also found that less intense, shorter pulse duration resulting in filling in of the photoreceptor layer. So here you can see conventional single spot PRP applications, and then you can see the uniform pattern of Pascal on the right here. And you can see the difference in the uniformity that you can achieve with these Pascal treatments. We found that less intense, shorter pulse duration resulted in no permanent damage to the photoreceptor layer and resulted in restoration of the retinal ganglion cell receptive fields, as you can see here. So what you can see here is initially for these shorter pulse durations, you got this damage that over the course of 2 months actually resulted in filling in. And since I left working with Daniel Palenker during medical school, this really led him to develop non-damaging retinal laser therapy with Endpoint Management. He did remarkable studies that Victor showed in his presentation, looking at 30% in finding the changes to heat shock protein induce changes without causing cellular damage. So after we've kind of found this work of less intense, shorter pulse duration, he really pioneered some amazing work on this that really was the foundation for endpoint management that we're discussing today. So what I sought to look at, as Victor brought up, anti-VEGFs are incredible, and they result in a significant improvement for patients. But as we all know, frequent intravitreal injections are very difficult on patients and their families. And COVID-19, I think, has really highlighted this point because patients don't want to be coming in every 4 weeks as they did in a lot of these clinical trials. And so many patients have a lot of concerns about coming into the clinic. So what we sought to do is evaluate patients with diabetic macular edema and the use of adjunctive endpoint management laser therapy to reduce the burden on clinic visits and intravitreal injections of these patients. So these are patients that are getting anti-VEGF injections, and we're adding on endpoint management laser therapies. At this point, we have 18 eyes from 14 patients, probably pretty regular to many of your clinics. The mean age was 62.6 years of patients with diabetes. Half the patients were receiving bevacizumab injections prior to laser treatment. 29% were receiving aflibercept, and the remaining 5 were receiving a combination of anti-VEGF and steroid agents. Now, as you think about giving these treatments concurrently, you do have to think about if one can affect the other. And we did actually evaluate in the addition of steroids, basically, while it can affect more intense laser burns, was found to have no effect on barely visible or non-damaging laser burns. So you don't have to be worried about the concurrent use of anti-VEGF steroids and these endpoint management laser therapy. So the key take home from this is that we found that endpoint management nearly halves the number of injections without compromising the macular edema or the vision. So if you looked at the 6 months before endpoint management, these patients were coming in 4.5 times and receiving 4.5 injections. After we did endpoint management in the 6 months afterwards, these patients got a mean of 2.33 injections. So nearly halving the number of injections and really halving the number of clinic visits. So rather than coming in every 4 weeks, as many of these patients, and the patient I showed at the beginning, where you can have them coming in every 2 to 3 months. And this is with a single endpoint management treatment. As Victor brought up, you can certainly repeat that, but this is actually with a single endpoint management therapy. If you look at the central subfield macular thickness before and after, you actually see a trend for an improvement in central subfield macular thickness. We weren't really trying to achieve a complete resolution. We were really trying to space out the visits. So it's not statistically significant. That really wasn't the point of what we were trying to achieve. What we were trying to achieve was the top point, which is having patients come in less frequently and having patients get fewer injections. And on the bottom, if you look, the visual acuity actually slightly improved, but again, not statistically significant. But again, that's not what we were trying to do. What we were trying to do was space out patients more. So the key take-home message is vision wasn't reduced. The central subfield thickness wasn't really changed. And yet you could just give half the number of injections to these patients, which really for these patients improves their quality of life, their ability to live life and not have to come into the clinic as frequently, particularly during the COVID-19 pandemic. These are the settings that I like to use. As they mentioned, 30% of threshold laser. I typically find a mean threshold power of about 140 milliwatts or so. You titrate up. You see in each individual patient. In our study, the mean was basically 140 milliwatts. I turned the landmarks off using a laser spot size of 200 microns, a pulse duration of 15 milliseconds. All these were first-time treatments. We used 0.25. And the mean number of spots in our study was 655 laser spots that were applied. So I typically do a circular pattern, excluding the 2 nasal quadrants that are the macular-papular bundle, and then do supplemental 4x4 squares surrounding that for my endpoint management. That's how I typically like to perform it. So some benefits and versatility of endpoint management, in my opinion, is it's a really rapid treatment. And this is something where patients have absolutely no pain. So this isn't like PRP where patients are in excruciating comfort. Most patients don't feel anything at all except for the macular contact lens. One of the nice things, as I mentioned, the patient had chronic kidney disease. Many of our patients with advanced diabetes, as we all know, have kidney disease and are hesitant to receive fluorescein or anything that can be renally excreted. So a lot of these treatments with endpoint management, you don't necessarily have a requirement to do fluorescein angiography on these patients. As I mentioned, it reduces the injection requirements. You can space out the interval between clinic visits from every 4 weeks to every 2 or 3 months. And it has a trend, although not statistically significant in our small sample size, to improve vision and reduce OCT central macular thickness. So what are the pearls that I have? I think it's very important with any procedure or anything to set appropriate patient expectations. So I typically treat patients with this with severe diabetic macular edema, and I counsel them from the beginning that the laser will reduce the number of injections and visits, but typically doesn't eliminate the need for them. So I don't want them to expect that they're going to get this laser treatment and they never have to see me again and everything will be perfect. Realistically, in patients with severe DME, they'll still need injections afterwards, but if it's half the number, that's great. You could consider it certainly as monotherapy for mild edema. I typically use it for more severe edema, but it certainly is indicated and reasonable to do it in both. And as Victor mentioned, you really want to counsel these patients. They're not going to see an immediate effect. So these patients, especially the ones I treat, are typically used to seeing this effect with anti-VEGF therapy 2 or 3 days later. That's not what happens with laser therapy. So I always tell them laser is a longer term effect, which is nice, but you're not going to see this wow factor like after anti-VEGF injections where 2 or 3 days later, the vision kind of pops clear. I typically select patients who need frequent, oftentimes monthly injections and tell them this will extend the interval between visits. Just walk through patients what to expect and through the laser process. And as Victor mentioned, the important thing during treatment is to keep track of what area you've treated if you're not using the visible landmark. So I turn off the visible landmarks, and it's very important as you're doing treatment to just remember this is the area that's been treated. This is the area that I still have left to treat. When you're doing the circle, it's nice because it just walks you through that. But as you put in the spots afterwards, that's when you need to remember that. So I'd like to thank all the members of my lab, a couple of residents and medical students that actually evaluated the data that I was presenting today for all their hard work. I'd like to thank our sources of funding, primarily the National Eye Institute, along with a number of other foundations. And I'd like to thank you all very much for your attention. So I welcome the discussion at the end of the presentations, along with welcome any questions that you have. So without further ado, I will turn it over to Dr. Rodríguez to discuss his experience with endpoint management on a different disease, central serous chorioretinopathy.
I would like to thank Iridex for the invitation to participate in this webinar, and also acknowledgement of my co-author, Willie Carpio, one of my fellows. This is my financial disclosure, and this is the outline to be developed in this presentation. Central serous chorioretinopathy is a disease with a multifactorial etiology characterized by the localized serous detachment of the neurosensory retina with or without the presence of the RP detachment and RP alterations. It's more common in men. It's still idiopathic, and there is a spontaneous regression of the disease in 3 to 4 months with good visual prognosis. However, there are chronic forms with persistent serous detachment and progressive visual loss. In 2013, Betty Frown coined the term pachychoroid pigment epithelopathy, and central serous chorioretinopathy is now part of this spectrum of the pachychoroid disease, which happens to be a disease that shares the following characteristics, such as the anomalous dilation of choroidal vessels, thinning of the subtler layers and the choriocapillaries, the presence of subretinal fluid associated with or without choroidal neovascularization, and changes in the RPE and the external retina. The pathogenesis is still unknown, but there are multiple etiologies and mechanisms that include the choroidal circulation abnormalities, in which there is sympathetic abnormalities, congestion, and intervertex anastomosis, which leads to a choroidal thickening and pachyvelsis, and ends up with the choroidal hyperpermeability. There are also RP alterations, in which there is an increase in the tissue hydrostatic pressure, which exceeds the barrier function of the RPE, and ends with the detachment and the alteration of the RPE. And finally, the presence of serous detachment, which is a fluid entry into the subretinal space. There are also associated factors that include the genetics, the use of exogenous corticosteroids, the high blood pressure, the coagulation abnormalities. It has been also described that the MEK inhibitors may present the clinical picture that is similar to central serous, and the use of cigarettes and alcohol. Recently, Jay Chablani, on behalf of the Central Serous Chorioretinopathy International Group, published a new classification based on the multi-imaging, and was classify the disease in simple and complex. And both groups included a primary, recurrent, and resolved, and also a third type, which is the atypical. Ancillary tests are several, and we like to use all of them. Fundus photos, color fundus photographs are very useful to delineate the serous detachment. Autofluorescence is also very important to learn more about the RPE with the images showing hyper and hypo autofluorescence, and also the track that has been described by Yanis several years ago. ICG is also very important nowadays. That is important to learn more about the intervertex anastomosis. However, ICG is banned in Colombia and we cannot use it. Fluorescence angiography can be used either focal or panoramic, since now we can see several changes in the periphery, such as the track. And the OCT is becoming the most important ancillary test for the diagnosis and follow-up of patients with central serous retinopathy, in which we can see the alterations in the RPE, the serous detachment, and also the RPE detachments. OCT angiography is also very important, which helps us to rule out the presence of choroidal neovascularization in some patients that may develop these abnormal vessels. We recently published a central serous retinopathy imaging biomarkers with Jai Chevilani and his group, in which the objective was to identify the predictive factors of visual and anatomic response at 12 months. It included 97 patients with acute phase and 134 patients with the chronic cases of central serous. In the multivariate regression analysis, we've found that the changes in the central retinal thickness and subretinal fluid height were predictive factors for good visual acuity. And also in the logistic regression analysis showed that changes in the central retinal thickness and subfoveal choroidal thickness correlated with the resolution of the disease. And in most of the macular diseases, the integrity of the ellipsoid zone is associated or was associated with good visual acuity. For treatment, on your right, you can see there is an algorithm that has been published for the treatment of central serous, which is quite confusing, and we don't use it. We like to start with observation in most patients because there is a spontaneous improvement in the acute conditions in 3 or 4 months. However, in patients without the need active treatment, it's advised when there is recurrences or to avoid chronic conditions. Also, early treatment we use in patients who require rapid visual recovery, such as pilots, architects, or physicians. Laser photocoagulation is used rarely now because of the adverse events. However, it was very common some years ago, in which a laser spot was applied to the RPE detachment. Subthreshold laser is now my preferred treatment of choice for patients with central serous chororetinopathy, either chronic or in the acute phase. Photodynamic therapy was also very useful, and we use it a lot in patients with central serous. However, we cannot use it now because vector porphyrin is not available even in Asia. Anti-VEGF treatment is also useful in some patients with central serous and has been used quite often in some patients with central serous chororetinopathy, even in chronic patients. And pharmacological treatments have been used as well, but none of them has become useful for the treatment of central serous chororetinopathy. There is a recent paper published by the Schorma and his group from Germany, in which they use subthreshold laser therapy with the standard macular treatment for chronic central serous retinopathy. They included 42 eyes, 39 patients with central serous with a minimum symptom duration of 4 months. At the end of the study, there was a complete resolution of the subretinal fluid in 42.6% of the patients at 6 months and 53.8% at 12 months after baseline. Central retinal thickness, subfoveal choroidal thickness, and microperimetry derive macular function and best corrected visual acuity, improving significantly in these patients. And you can see on the right, in the upper right corner, the pattern of treatment. This is the treatment that I like to use in patients with central serous. These are parameters. I use a power between 100 and 120 just to titrate these patients. I use the endpoint management between 30 and 50%. And this is the pattern that I like to use in patients, even in both in acute and chronic phases, patients, and in which I repeat most of them the same pattern. I like to use the fixation light because it helps me to find the fovea very well, and I feel comfortable using it. This treatment has some pros for me because it reduces the functional and structural damage to the retina, and also helps me to treat more patients because they the high speed in the treatment of these patients for diabetes or for central serous retinopathy. And now let me share with you some of the cases that I've using that I've been treated with Pascal for the central serous retinopathy. The first patient is a female, 37-year-old female with scotomas and decreased vision acuity in both eyes. It was a bilateral disease. This is the right eye, showing that there was the patient was treated with laser spots along the supratemporal arcade. There were also some changes, as you can see, in the autofluorescence in the fovea, and the fluorescent angiography in the late phases. You can see that there was a hyperfluorescent spot that was present in the nasal aspect, and was the cause of the recurrence of the disease. The OCT showed that there was a serous detachment of the macula involving the fovea, and this patient was treated. And this is the left eye that also had the disease and also was active at the same time. The autofluorescence showed the changes in the RPE, and the fluorescent angiography showed some hyperfluorescent spots in the macular area outside the foveal area. The main one was in the temporal aspect, but I decided not to treat that one, but use the Pascal laser for the treatment of the disease. However, after the treatment, the patient got worse, and she had some more fluid, subretinal fluid in both eyes after the treatment. So I decided to treat her again with the Pascal laser using the same parameters. And this is the patient 3 months after the treatment with a resolution of the fluid, the subretinal fluid in both eyes, and the visual acuity remaining in the same level of 20/40. This is another patient, a 45-year-old male who also complained of scotoma and distorted vision in his left eye. He's a physician, and since then we decided to treat him early. The fundus color photograph showed the serous detachment, and the autofluorescence showed the changes in the RPE. And he had a typical presentation of the fluorescent angiography. However, I decided to treat him with the Pascal laser. On your right side, you can see the serous detachment that was involving the fovea in his left eye. His visual acuity was 20/40. After the treatment, there was a resolution of the subretinal fluid, an improvement in his visual acuity to a level of 20/25. And this is the last case, a female patient with scleritis in her left eye. She also had rheumatoid arthritis and was under treatment with prednisolone that we associated with the presence of central serous retinopathy. There was a large serous detachment, as you can see on the OCT. We decided to treat her also with the Pascal laser, and this is after 3 months after treatment that her visual acuity improved, as well as the serous detachment of the retina improved and disappeared the fluid. So as a take-home message, the central serous is a multifactorial disease with unknown pathophysiology. The role of vascular hypermeability related to the mineralocorticoid pathway is the most accepted concept at the moment. Most cases resolve spontaneously, requiring treatment for chronic and recurrent forms to avoid anatomical functional damage. Multimodal images have allowed us to better understand the disease, and we use them for both the anatomical and functional prognosis. There are different treatment options, being the subthreshold laser, a safe alternative that I like most to use now in my patients with central serous retinopathy. Thank you very much.
There are a few questions that have come in that I think are really good ones. And for you, Francisco, the first one is, since we feel that endpoint management is relatively safe, have you thought about intervening earlier in these patients instead of giving them that 3 to 4 month observation in patients with CSR? Would you still consider waiting the 3 to 4 months?
I started earlier now the treatment for most of my patients with central serous. You're right. It is a safe technique, and I feel comfortable treating these patients earlier. Most of the patients that I show you were treated as soon as they were seen. The physician and also the other patient was a female that was dedicated. They needed her vision to improve for her work. So I treat them very early in the disease. You're right.
The second follow-up to that is, how much spacing do you give yourself if you require more than one treatment for these patients?
I like to repeat the same pattern for the treatment, which is has some spacing that is 0.25, and I feel comfortable with this spacing for the patients. This is my standard treatment that I do use now for patients.
Excellent.
How about you, Victor?
I agree with you. I feel very comfortable with the laser as long as we use those parameters that we talked about. I've been that's my first line of treatment now for CSR on these patients, and I followed them up initially, obviously looking at autofluorescence and other parameters to make sure that, in fact, I wasn't causing any change in my treatments. And I completely agree with you. It's as long as we stay within those parameters, it's very safe and it's very effective. And I can have, some of these patients do give me a wow effect actually with CSR. Paulus, unlike like DME. Unlike DME with CSR, I can see resolution 80-90% of the fluid within 2 to 3 weeks after the treatment. And so these patients notice that reduction in the scotoma. As you pointed out, Francisco, these are younger patients, working patients, and getting rid of that scotoma really, gets them back on to work faster. There are some questions for Dr. Paulus also. A couple of questions. First of all, that was excellent. The comments on using this for extending the treatment is obviously very interested to me and to the rest of the group. I mean, one of the questions is, when you start looking at these patients, how many anti-VEGFs do you give? Do you have a pattern, or do you have a central macular thickness before you consider, using the endpoint management? That's number one. And then, how often do you consider retreatment, and what are the biomarkers that you use?
Yeah, those are great questions. And thank you very much. And thanks to all the attendees also for sending in the questions. There's not a set central macular thickness that I use. As I showed in the study, our central macular thickness was in the low 300s or so. So I don't necessarily base it on that. I base it on kind of the injection burden, the patient's social factors, their concern and their interest with extending their treatment interval. So there might be some patients with relatively not so thick central macular thickness, 300, 320. But if you extend them beyond 4 weeks with anti-VEGF agents, it might jump up to 450 or beyond. So I base it very much on each individual patient and really having a more personalized treatment. So I can't say there's a central macular thickness that is kind of a cutoff that I use. In terms of deciding for endpoint management, I really base it on the patient and a discussion with them. So usually I almost always start with anti-VEGF injections, unless for whatever reason patients, as I think, Victor, you brought up an example of a patient that absolutely refuses injections, and I think we all get those sometimes. But I think most patients, given the visual acuity improvements with anti-VEGF agents, I'll start them there. If they require very frequent injections and so forth, those are the ones that I will offer endpoint management and try to use that to extend the interval between them.
Francisco, do you have any experience with that?
No, I do not, but I have a question for both of you. Although there's some studies on the treatment of non-central involvement of diabetic macular edema. Have you used it in those cases with non-central involvement of the macular edema?
Well, that's my exclusive treatment for those non-center involved patients, because as you know, we have no data in those non-center involved with the anti-VEGFs up to recently. And I've been very comfortable treating those patients that have significant edema, not involving the macula, with the endpoint management. And I must tell you, I've had good outcomes with that.
I would completely agree. So I think those are a great indication for it. I mean, I actually do treat them also in center involving ones, but I will also treat ones not center involving.
Okay. So I think, obviously those are, two very, very helpful approaches to this. I mean, The one other question that they had here for you, Paulus, was Dr. Paulus was, do you only give one treatment, or now that you've come comfortable, do you give multiple treatments, and what's your indication for multiple treatments on these patients?
So we didn't evaluate that in our initial study. We were looking at a single first treatment with endpoint management. Now that I have longer term follow-up, and now that COVID-19 has been going on almost 2 years, I certainly think that it can be repeated. And we certainly know from focal laser that it can be repeated. As Victor brought up, probably about as frequently as every 3 months. I tend to do it more on the order of about every 6 months or so. But I think anywhere from 3 to 6 months is very reasonable. And I think if it seems like a patient is requiring numerous continued anti-VEGF injections, I do have a good experience doing retreatments after that period of time. I tend to actually use the same parameters. I don't necessarily actually change. I know Victor brought up changing the spacing in between the laser applications. That seems very reasonable. I typically don't necessarily change that on my retreatments. And on the retreatments, I've actually had a similar good response as I did with the initial treatment. So it's not something where I'm so concerned about tachyphylaxis or patients not responding to subsequent laser treatments. I think they respond excellent to additional interventions. And I think anywhere from 3 to 6 months is very reasonable to consider retreatments.
Now, for you, Dr. Rodríguez, again, how often do you retreat these patients? How much time do you give them after your initial treatment for CSR to retreat them?
I usually see them a month after the treatment, and then I repeat the exams about 3 months after the laser. And if I see the recurrence or persistence, I repeat the treatment. But most of the patients resolve, and probably some patients may have a recurrence. So I feel comfortable waiting after 3 months for treatment or retreatment after seeing the OCT in these patients.
Okay, and when you retreat, do you change your parameters, or are they the same parameters?
I use the same parameters. I like to use initially 30% endpoint management, and then for chronic cases or recurrence, I decrease to 50% endpoint management. That's the way that I use when I have to repeat, or when I see chronic cases. One of the cases that I showed there was treated in that way.
Now, one of the other questions that they had here was, after you do the pattern, do you ever treat subfoveally?
No, that's why I use the light, because I want to be sure that I'm not treating the fovea. Is to make sure that, yes, that's a good question. I never try to treat it. Do you?
No, I've never tried to treat subfoveally.
I think most of us, are comfortable doing that. And if we think about what we're trying to achieve, right? What we're trying to achieve is increasing the expression of heat shock protein. So theoretically, as long as we can give a nice treatment around the fovea, we should have some diffusion of those factors and that benefit. And it looks like, by the results you both showed, certainly there's some of that benefit occurring, centrally as well. So I don't think, and I agree with you, that subfoveal treatment isn't necessary and when using these approaches. There was a question also for the panelists. Has anybody used this to treat macro aneurysms? Dr. Paulus, have you used that?
I don't have an experience with endpoint management in that. It seems very reasonable for ones that are leaking and you get edema. That doesn't seem unreasonable. I tend to, at this point, do more thermal photocoagulation than anything else for those if I need to, but I've never used endpoint management.
Dr. Rodríguez, do you have any experience?
I have no experience with treatment with endpoint management for these patients. Yes, I agree with Yanis Paulus.
Yeah, I mean, I'll tell you, it's a great thought as well. I also do not have experience. I'm with you, Yanni. I use laser. Usually bigger spot size with I don't use. I use longer exposure to try and reduce potentially the risk of popping a hole in them, and I go just around the base to try and cause a little thermal reaction. And do any of you treat them directly on, or do you go around the base?
I typically go around a circle around the base first, and then I oftentimes will go to the area itself with a longer pulse duration, as you mentioned, Victor. So, but I typically I will go to the center and actually treat that also, but I treat around it first in a circle in essence.
I do the same. I like to do the same. Yes.
Perfect. Let me see. Someone just send us something here. This is from.
There's also a question,
Okay.
Victor, about a minimum number of spots to treat. So as Victor brought up, I think typically we target more than 500 spots oftentimes, or right around 500 spots. In our study, we did a mean of 650 laser spots. I don't know that there's a magic number, but I would say typically we're targeting somewhere around 500 to just really paint the macula.
I agree. I mean, I think I'm usually somewhere right around 500 to 700, depending on, if there are large areas with edema outside of my treatment zone. I actually will use the little square, to go and treat some of those areas outside that treatment zone. And I may be overdoing it, but I like to try and dry up my macula as much as I can. Do you do anything like that, Francisco?
No, I do not. But I agree with you, Victor.
Okay. Let me see. There was a few more questions coming in. Well, some of the panelists are commenting that they use the endpoint management or micropulse in the area of the edema, and they use photocoagulation to the macroaneurysm. So I think, even amongst our participants, there seems to be a predilection to use the thermal approach on the macroaneurysms, and I would tend to agree. Although, it'd be interesting to do some controlled evaluations on using EPM on those macroaneurysms, because, it might work. It's just that I haven't really tried it.
There's also a question about if you can treat DME patients that also have epiretinal membranes. So I certainly actually treat a lot of patients with DME that have ERMs concurrently. I mean, certainly you want to think about how much of it could be related to traction as opposed to how much of it is related to leakiness from the DME. I don't think that endpoint management would probably relieve any traction from an epiretinal membrane. But there are many patients that have both, and I think the tractional component is relatively small, particularly because I can see a lot of changes with anti-VEGF injections. So if that's the case, probably a large component of that is not tractional. A lot of it's related to the DME, and I'll treat those, and I've had a great response in those patients too. So it does require a little bit of teasing out about how much you think is tractional as opposed to how much you think is more related to the diabetic macular edema, but I have treated many of those patients and had a good response.
Good point.
I agree. I mean, I think you have a similar no response with ERMs and anti-VEGFs as well. So I think, it's important to really assess whether there's traction or not, but it won't hurt to try it, because I think, sometimes we get surprised even with the anti-VEGFs in these patients with ERMs, they respond well. Well, in order to respect everybody's time, we're getting close to the end here, and I'd like to, thank first of all the panelists for being on the call and all the great questions and interaction that we've had from you. And I'd like to thank Dr. Paulus and Dr. Rodríguez for their exceptional presentations, and of course thank Iridex for making this possible. I think, I've learned a lot, and hopefully, we've shared a lot of information that can be, utilized to, improve the treatment outcomes in your patients, not only as a first line, but also, as was discussed here, improve the burden that these poor diabetic patients have to go through with all these injections. I'd like to thank everybody for the time, and, good night or good morning, wherever you're at. Thank you.
Thank you.
All right. Thank you very much.